Good afternoon. Thank you for joining the webinar on the national findings on mental illness and drug use by prisoner and jail inmates. My name is Sarah Worsberg, and we appreciate you joining us today. We're looking forward to the discussion today about the findings of 2 June 2017 publications by the Bureau of Justice Statistics. The first is on indicators of mental health problems reported by prisoner and jail inmates from 2011 to 12. The second report is on drug use, dependence, and abuse among state prisoners and jail inmates between 2007 and 2009. The focus of this webinar is going to be to review the findings with Jennifer Bronson, who's a Bureau of Justice Statistics statistician, and then we're going to follow up and discuss how jurisdictions around the country can utilize this information locally. So on the webinar today, we have a few different speakers. The first speaker we're happy to welcome is Jennifer Bronson from the Bureau of Statistics. She's a statistician. Jennifer has been a statistician at BJS for about 3 years, where she works on projects related to correctional health, juvenile justice, and children's exposure to violence. Prior to BJS, she worked for the Virginia Department of Behavioral Health and Developmental Disabilities, the Partnership for People and Disabilities, and Offender Aid and Restoration in Richmond, Virginia, as well as in academia and for an international NGO. She's active in the American Public Health Association's Maternal and Child Health section and was recently named the section's 2017 Young Professional for her research. She has a bachelor's degree and master's degree from Virginia Commonwealth University and received her doctorate in medical sociology from Harvard University. So thank you for joining us, Jennifer. Our second speaker for the day is Bonnie Sultan. Bonnie is a grantee technical assistance manager for corrections and reentry at the Council of State Governments Justice Center. Bonnie leads technical assistance to grantees under the Smart Reentry Grant Program, which is part of the Second Chance Act grant program. She specializes in programs at the intersection of criminal justice and behavioral health. Prior to joining the CSG Justice Center, she served the County of Santa Cruz, California, as an analyst leading the development and implementation of policy and procedures following statewide prison realignment. Bonnie has direct experience working in a variety of correctional settings where she took part in alternatives to incarceration policy development, R&R implementation, in-custody programming and procedures, and cross-agency training. Bonnie received her bachelor's degree from Ithaca College and her master's degree from George Washington University and a master's degree from John Jay College of Criminal Justice. Thanks for joining us, Bonnie. And I am Sarah Worsberg. I'm a Deputy Program Director for Behavioral Health at the Council of State Governments Justice Center. In this role, I oversee technical assistance, training and technical assistance for the Justice and Mental Health Restoration Program, as well as the Second Chance Act reentry program for adults with co-occurring substance use and mental disorders. I also oversee our courts work and our substance use disorder work. Prior to the Justice Center, I have experience as a research analyst at the National Association of State Alcohol and Drug Abuse Directors, leading their pieces on youth and women's services, as well as writing research reports. I also worked in community-based substance use disorder prevention and as a juvenile court advocate. I'm a graduate of SAMHSA's Women's Addiction Services Leadership Institute. I have a bachelor's degree from DePaul University and a master's degree from the University of Chicago. So that is an introduction of our team members who will be speaking today. Just to give you a little bit more background for those of you less familiar with the Council of State Government Justice Center, we are a bipartisan policy solution organization dedicated to serving all three branches of government. Within the Justice Center, we focus on specific criminal justice issues related all across the spectrum. This is specifically focused on behavioral health, but we also have teams focused more specifically on law enforcement, on reentry, on justice reinvestment, and on juvenile justice. So this grant specifically is brought to you through the Justice and Mental Health Collaboration Program funding, and this grant program was created to focus on partnership between criminal justice agencies, including law enforcement, corrections, and community corrections, and mental health providers and substance use disorder providers to make sure these grantees were working together. So this webinar today, we're going to start with passing it over to Jennifer to talk about the national findings on the mental illness and the drug use by prisoners and jail inmates. Then we're going to talk a little bit about thinking through how to use the information that Jennifer will provide in jurisdictions locally. And then we're going to talk about specific considerations for research and evaluation and how to develop those partnerships to make sure we're getting strong outcomes on all the programs around the country. So with that, I'm going to pass it over to Jennifer to begin to talk about the first study based upon mental illness.
Okay. Hi, everyone, and thank you for the introduction, Sarah. Just one clarification, though, which some might find funny, but my PhD is from Howard University and not Harvard, so I wanted to make that clear. So today, what I'm going to do is I'm going to first discuss the findings from our most recent mental health report and then move into findings from our also very recent drug use report. Some of the information will be the same, such as the methods, so I'll discuss that more up front so that we can go through the data. Okay, and this report, The Indicators of Mental Health Problems, was written by myself and Marcus Brzozowski of RTI International. So I work for the Bureau of Justice Statistics, which we're one of the smaller agencies in the Department of Justice, small but mighty, and we're one of the 13 federal statistical agencies. Our mission is pretty simple. We collect, analyze, and disseminate statistics on crime, the criminal justice system, and victimization. We do not make policies. We typically don't give grants for programs and services. That's your Bureau of Justice assistants. And we also don't typically fund research or research proposals. That's the National Institute of Justice, and people often get us confused with those two other great entities. All the data that I'm presenting today is available on our website, bjf.gov. The full reports are published, and you can find all the information online. Okay, so our mental health report. The purpose of this report is to present self-reported estimates of mental health indicators among prison and jail inmates. Some of the things that we do in this report, we compare prisoners to jail inmates. And for those who aren't aware, there is actually a difference between prisons and jails. Although, you know, Law and Order uses them interchangeably, there is actually a difference. Typically, somebody sentenced to prison has committed a more serious crime. They have already been sentenced, and their average length of stay for prisons is about 2 years. Whereas for jails, you're going to have an unsentenced population being held awaiting trial, and that's almost 50% of your jail population has not been sentenced. And your average length of stay for jails is about 2 weeks or 10 days. So there is quite a difference between these two populations. We also compare the inmates to the general population so we can kind of ground it in a larger context. We look at demographics, criminal justice variables. We dive a little bit into treatment for mental health problems since admission to the current facility. And we also look at rule violations while incarcerated. Okay, so our data source for both of these reports, the mental health and the drugs, comes from our National Inmate Survey. And we've conducted this survey now 3 separate times. The first time was in 2007, the second was in 2008-09, and those 2 data collections were combined for our drug use report. The third report, or the third survey, was conducted in 2011-12. Now, the purpose of NIS is actually not to collect correctional health data. The purpose is to collect sexual victimization data from inmates. and this is a mandated project for BJS to do under the Prison Rape Elimination Act. So what we've done, and I don't want to go into too much detail, but this does provide context for why our drug use report is 0709 and not 1112, is we basically had to build in kind of a double-blind research design. So for example, if Bob is over there detailing sexual victimization and he's got a lot to report and he's filling it out and he takes 45 minutes, and then John takes 5 minutes and flies through it because he doesn't have anything to report, then guards and other inmates will know, well, Bob was reporting something. So we build in a blind randomization where 90% of the sampled population gets the sexual victimization survey. 10% gets the alternative survey, which has no sexual victimization information at all. So when the person who's in the sexual victimization sample is finished, and if they still have time left, because this was built-in timer with the computer, so average about 35 minutes, then they would go on and start taking the modules in the alternative survey, and they would finish until they ran out of time. So what happened is that the drug use data fell very high in the alternative survey. It was basically the first module that they got. But then for 2011-12, we moved it so that the mental health module came first and the drug use came second. So when we did the bias analysis of the drug use data from NIS3, we found out that it was indeed biased. It was biased towards inmates who did not report sexual victimization, who did not report mental health problems, or very few, and who spoke English. So for that reason, that is why our 079 is our most usable data on drug use. And if you want more details, I'm happy to talk about it in a little bit later. We collect all of our data through inmate self-report. We use a CASI, and this is a nationally representative sample. And as you can see, it's quite large. We survey tens of thousands of adult inmates, and we go to both state and federal prisons and jails. We also use the NSDA data from SAMHSA, and we love using the NSDA data. Again, it doesn't do us too much to just know the percentage of inmates with a mental health problem if we don't have anything to compare that to and to see what it looks like in the population as a whole. So we use NSDA for a couple of reasons. First is that they use the same indicator as us, so that is very helpful when trying to make comparisons. And that indicator is the past 30-day serious psychological distress, and I will talk about that more in a few slides. We also standardize all of the NSDA data, and this is because the prison and jail populations not only look different from each other, but they look different from the general population. And some of these differences, such as sexual differences or race differences, can in fact affect the outcome that we're looking at. So all the data that I'm presenting has been standardized, and that basically just means we've made the general population look like the prisoner population or the jail population. But the best thing about NSDA is that it has this neat indicator of criminal justice involvement in the past 12 months. So we can see the people who have had no involvement, those on probation or parole, or those who have been arrested in the past 12 months. And we did combine several years' worth of data so that we could get a large enough sample size to do some of the analyses that we needed to do. So for the mental health report, we used data from 2009 and 2012 to increase our precision estimates. Okay, before I get into the findings, I want to talk a little bit about measurement because this does make a difference. The two indicators that we use, and we basically use these to indicate that an inmate is likely to have a mental health problem. We don't look at medical records. We don't verify this with, against a clinician or a clinical diagnosis. And again, this is a self-report survey that we're doing kind of quick and dirty. So we use the K6 scale, and this measures serious psychological distress, and we use the past 30-day time frame. So in the past 30 days, did you have such and such? And SPD is determined by a score of 13 or plus on the K6 scale. And again, I'm going to look at this again in more detail on the next slide. And the second one we use to kind of assess if somebody has a history of a mental health problem or perhaps a lifetime mental health problem. And this is the question: has a mental health professional ever told you that you have a mental disorder? Now, this could mean that they were ever told yesterday, they were ever told 30 years ago, they were ever told 8 months ago. So we're using history in kind of a general sense of the term. And these indicators are not mutually exclusive, so an inmate could have SPD and have ever been told, they could have none, they could have one, they could have both. Okay, so what is the K6? The K6 is a general population scale. It's used widely. It's used in NISDA, BARFIS, to identify individuals who are likely to have a serious mental illness, and then should be followed up with a proper assessment and diagnosis. It's comprised of 6 questions. In the 30 days prior to the interview, how often did you feel nervous, hopeless, restless, or fidgety, so depressed nothing could cheer you up, everything was an effort, or worthless? And then this is scored with a range of 1 to 5 for each question. So all of the time I felt nervous, or none of the time I felt nervous. This gives us a score range of 0 to 24. We reverse code it, and based on the guidelines that Kessler, the man who developed the scale, the guidance he's put forth, we use the same cutoff point of 13 or higher to indicate the person has SPD. If you're interested, a score of 8 to 12 indicates an anxiety disorder, and a score of 7 or less indicates that they do not have, they're unlikely to have a mental illness. A few things about SPD: it is not a mental disorder, and it's not a diagnosis. Again, it's just an indication that a person is likely to have a problem and should be followed up for assessment.
So Jennifer, this is Bonnie. We're getting a couple of questions as you're talking about this a bit, and just for clarification, people are asking online, how do you account for people who are unaware of their mental diagnosis or status? So for example, is there a cross-reference in your study, or do you take a look at medical documentation, or is this all self-report?
It's all self-report. We just basically have to take their answers at face value. We have no way to assess it or verify it or cross-check it. Again, we've interviewed about 100,000 inmates, and it just would not be possible to get into that type of detail.
Great. And we're also having a question from one of our participants that is a defense attorney that has several of their clients are diagnosed by family practitioners or family physicians, and they're just wondering, in your definition, does a mental health professional include a family physician, or are you simply looking at people who are mental health professionals?
A family physician, I think, would fall into that as well. I don't believe that's specified in the exact question wording, but it does say a doctor, you know, doctor, psychiatrist, counselor. So I think that would fall into it as well.
Thanks. And for those of you who are online, if you have any questions, feel free to keep getting them into us, and we will ask Jennifer as they roll in. Jennifer, I'll let you get back to your slides. Thanks.
Okay. So we're getting ready to go into the tables and figures. There are going to be a lot of tables and figures, so please don't get too glazed over with the eyes. The statistics I'm going to present are pretty simple. They're basically just counts and percentages. There's no sophisticated regression analyses or modeling. So what we will note throughout, and I'll kind of call your attention to this as needed, is that we did do significance testing, and our 1 asterisk designates the comparison group, and then the 2 asterisks is that the difference with the comparison group is statistically significant. So that just means, in very simple terms, that the likelihood that a relationship between 2 variables, so for example, a person's racial identity and SPD, is caused by something other than random chance. If you remember back in the Statistics 101, this deals with whether or not you reject the null hypothesis or accept the null hypothesis. Now, some of our data, our findings are insignificant or statistically not significant, but this doesn't mean that they're not important or that they're not real. It simply means that we are just not 95% sure that there is a difference. So even a finding of no difference, it's still an important finding. And as we look at some of the tables, this should become a little bit more clear. And for those of you who really like statistics, our standard errors are available for every single estimate, and those are presented in the appendix tables of the reports, which you can find online. Okay, so figure 1. So this is our big overview slide, and all of these tables and figures come directly from the reports. So serious psychological distress, you see our jail inmates are the green bars, our prisoners are the blue, and prisoners were our comparison group. So we were comparing prisoners to jail inmates, and everything was significant. So we found that 14% of prisoners and 26% of jail inmates met the criteria for SPD. The middle bar is our history of mental health problem, that ever told variable. And this is 37% of prisoners and 44% of jail inmates reported that they were ever told they had a mental disorder. And then lastly, we looked at those with no indication of a mental health problem. And so these are the people who said, nope, I've never been told, and they scored 7 or less on the K6. And here we see that 50% of prisoners and 36% of jailmates reported that they did not have a mental illness based on these indicators. This slide looks at prisoners, and it compares it to the adult general population. So what you see up top, you've got the prisoners, and that is our comparison group. And then the adult general population is the total. So that's everybody. Then the 3 bars underneath that are kind of our breakout groups by criminal justice involvement. And what's cool about this is you can kind of visually see that the more involvement a person says that they've had, they're closer to prisoners. So our arrestees are closer to prisoners than those in the general population with no criminal involvement. So prisoners were 14%, as we already said, and the total adult general population, about 5% had SPD in the past 30 days. Those with no past year criminal justice involvement was 4%. And those under supervision or on probation or parole was 11. So that's, again, getting a little closer to our 14%. And those who were arrested in the last year was 13%. And this is the same slide, except it's jail inmates. And this data, our NISDA data was standardized to match our jail inmates. So jail inmates, we've got 26%. Compared to 5% of the total general population. So this shows us that 5 times the number of jail inmates met the criteria for SPD than the adult general population. For those with no criminal involvement, it's 4%, under supervision is 11, and arrested is 14. So there does appear to be quite a difference between our jail inmates and our general population, as well as our prisoners and the general population.
So Jennifer, this is Bonnie again from the Justice Center, and we're getting a couple of really great questions concerning the slides that you're discussing on jail inmates. For example, we're having someone contact us from Oregon. Thank you, Oregon, for joining us today. They're working on diversion strategies for people within the jails, but their population are not yet to be sentenced. And so in order to learn a little bit more about their population, they're listening to this presentation, seeing what they can take away from it. And so they're wanting to know, in your sample, did you have folks that were sentenced and unsentenced, or just one or the other?
Yes. So what we did, this actually combined sentenced and unsentenced jail inmates. But there is a chart that's coming up that shows the breakdown between sentenced and unsentenced. And for this particular report, when we compared those 2 groups, we found that they were similar enough where they could be combined. For the drug report, it's different. That's actually only sentenced jail inmates. But that's a good question because there is a difference.
Great. So Oregon, the next couple of slides are going to be for you. And a few questions are coming in just about about your tools. So a couple of folks are just wondering why the K6 was chosen. And if you're going to be doing more of this in the field for folks who are on the phone, who are evaluators, would you also recommend them doing the K6, or you know, are there merits over other SMI screening tools?
Well, there's certainly no shortage of SMI screening tools, that is for sure. The main reasons that we went with the K6 is that it's easy to administer, it's pretty easy for inmates to answer, and it's easy to self-report. But really it was because we could use it there's general population data that is used at K6, and so we could compare our measure to that measure. Now, whether it's the best one, that's a different question, kind of the pros and cons. That's also a slightly different question. This will continue to be the indicator that we use. So from that standpoint, I would recommend that people in the field consider including it because then their measurements would be comparable to what we produce. So moving forward for our future inmate surveys, the K6 is what we're continuing to use.
Excellent, thank you. I'll let you get back to it.
Mm-hmm. Okay, so this slide is our, and I'm not going to read every number on these slides either, folks. This is our prevalence of mental health indicators by history of mental health problems, so the people that were ever told. Prisoners were our comparison group, so we see that jail inmates were statistically more likely to have said they were ever told. And I discussed some of the limitations later, but they could have ever been told while they were in jail or prison, so we don't actually know the location of that. It might not have been in the community. And we see that jail inmates were more likely to have been told they had every individual disorder except for personality disorder. And so this showed that there was really no difference in the percentage of prisoners and jail inmates who had a personality disorder, about 13% of both groups. So major depressive disorder was the first reported by both prisoners and jail inmates, about 24% and 31%. Bipolar was the second most commonly reported by both groups. And then for the third was actually personality disorder for prisoners, but that was very close to PTSD and anxiety. Okay. This is our demographics, and again, these numbers are just simply percentages. What is the percentage of people? Up top, the first row is the all inmates, and that's the same as figure 1 that we've already looked at. So I'm going to bring you all down to the sex characteristic between males and females. And males were our comparison groups. And so what we see are that females were more likely than males to have serious psychological distress and to have ever been told they had a history of a mental health problem. Now, some of that could be due to differences in treatment-seeking behaviors, for example, of the history question. But for both prisoners and jail inmates, these findings are pretty consistent and pretty stark that females were more likely to have an indicator of a mental health problem than males. We also see when we look at race that compared to white prisoners, Black and Hispanics were less likely to have SPD. For those who are wondering, our other race category, which I acknowledge is not the best term, but it's what we use, this category includes those who said they were American Indian or Alaskan Natives, Asians, Native Hawaiian or other Pacific Islanders, and persons of 2 or more races. And we also see when we look at the history indicator that Black and Hispanics were less likely than white inmates to have reported that they were ever told they had a disorder. When we look at age, there were not very many differences. So particularly for SPD for prisoners, we see that 18 to 24-year-olds were just as likely as 55 to 64-year-olds to report SPD. However, those who were older, above age 65, were more likely to have, or I'm sorry, less likely than 18 to 24-year-olds. So a difference of 15% versus 10%. And it's a fairly similar pattern with jail inmates as well, where we see not a lot of difference by age, although there are a few that exist kind of in that history, but not a lot of substantial difference. I saw a question pop up. Somebody wanted to know if we offered incentives to the participants, and no, we don't. And that's largely because we cannot. If the jail or prison facility allows, we will give the inmate a individually wrapped snack, like a pack of crackers, that they can eat while filling out the survey, but they cannot take it back to their cell or their pod.
And Jennifer, just to follow up, there are a couple of other questions we're seeing come in as well. How many of these folks were federal prisoners versus state prisoners within the sample?
I would have to go back and pull out the exact numbers. This is just combined. So I don't have that available, but if that person would like to email me, I can try and get those numbers for them.
Thank you. And then there was also a couple of questions about whether the event of incarceration created the SPD, or was there
yes.
higher prevalence because people are incarcerated, they might have increased level of mental stress.
Right, right. And that actually is something we're going to get to a little bit later in the presentation. You know, the short answer is we don't know through this particular data, because we don't know the onset, if you will, of the SPD. It could have lasted much longer than 30 days. It could have happened while they were incarcerated. It could have happened before. So unfortunately, we don't know. We don't know kind of that directionality between, did the mental illness lead to the incarceration, or did the incarceration lead to the mental illness? So from this data, we actually cannot untangle that relationship.
So we have a question coming in from Carissa over at the University of New Mexico Project ECHO. Great question, Carissa. So she's interested in learning a little bit more about the suicidal tendencies and to be included within the major depressive criteria. Was that part of the question?
We didn't assess suicidal tendencies. That major depressive variable was simply just self-report that they had ever been told that they had major depressive disorder.
Great. Thank you.
Okay, so this table will help our friend in Oregon, because it shows our unsentenced versus sentenced jail inmates. And this looks at indicators of mental health problems by most serious offense. So whichever, even if they committed multiple ones, whichever became their most serious is what we block them into. Prisoners incarcerated for a violent crime, about 17%. Were as likely as those incarcerated for a property crime, 16%, to have SPD in the past 30 days. Prisoners incarcerated for a violent crime were more likely to have SPD than those incarcerated for a drug crime, DWI, DUI, and other public order offense. But there was no difference observed between property and violent offenders. For prisoners with a history of a mental health problem, those incarcerated for a drug offense, DWI, DUI, or other public order offense, again, less likely than violent offenders who have been told they had a mental disorder. And we see again that property and violent offenders were equally as likely to have been told that. The pattern for jail inmates is pretty similar to that of prisoners. We see an estimated 29% of jail inmates have been incarcerated for a violent offense and have SPD. This was slightly larger, and it was statistically significant, it did test, than the percentage of jail inmates incarcerated for a property offense and then the other offense categories. There was a slight difference between rates of SPD among unsentenced jail inmates compared to sentenced, so there was a statistical significance, but you can see 23% to 29% is a relatively small difference, if you will, just substantially. However, there was no difference between sentenced and unsentenced jail inmates and reporting on their history of a mental health problem. And this is part 2 of that table. So we actually didn't see but so much variation when we looked at some of our other criminal justice indicators. We looked at sentence length to see if that could maybe inform some of the incarceration effect, as well as time served since admission to current facility to, again, kind of see if we could assess something about the incarceration effect or how that's happened. But again, without a clear etiology and patient history, that's pretty difficult to do. Among prisoners with SPD or a history of mental health problems, there was no statistical significance by sentence length. For jail inmates, there was some statistical difference where inmates with SPD were more likely to have a sentence of 5+ years, and chances are those people are going to be transferred to prison shortly. 25% of those compared to those with a sentence of less than 1 year, about 22%. Regarding time served since admission to their current facility, particularly for prisoners with SPD, we see that there's virtually no statistical differences. Surprisingly, the only difference that tested was that between those who have served 1 to 4 years since admission compared to those who have served less than 1 month. For jail inmates, there was a little bit of statistical differences observed for SPD and time served, where we see that about 29% have SPD who've served less than 1 month, and this compares to 26% of 1 to 5, 23% of 6 to 11, and 24% 1 to 4 years. So there's a slight decrease the longer they've been in the facility. And then for our history of a mental health problem, there was pretty much no differences at all by time served since admission.
Jennifer, we have a few more questions coming in. One is it possible to compare this data to the 2006 BJS report on mental health problems for prisoners and jail inmates?
It's possible, but we don't recommend it. And the reason why is that they were collected with different modes. We used ACASI and that used CAPI, but the indicators are different, and that's the main reason we don't recommend that. The 2006 report did not look at SPD and K6, although I think they do look at the ever told variable. So if my memory is serving me correct and that is there, that could be compared. But they use a different methodology and looked more at symptoms than they did the SPD and the ever told. So that's actually why we don't present trends in this particular report.
Gotcha. Thank you for that clarification.
Yes.
And did you see through the data and analysis, were there any indicators of differences based upon racial or ethnic disparities in inmates with mental illnesses?
Yes, we did see some racial disparities, and that was back on table 2, a couple slides back, where we saw that white inmates were more likely to have an indicator of a mental health problem than those who were Black or Hispanic. And that was generally the pattern for both prisoners, jail inmates, and it held true for both SPD and history. So we did see some racial differences that were significant. The other racial group did not test significant, with the exception of SPD and prisoners.
Great. Thanks again for that clarification.
Mm-hmm. So this one looks at criminal justice history. We looked at the number of times a person has been arrested in their lifetime. Now, they could have been convicted or not convicted. We just simply asked, how many times have you been arrested? What was interesting to us was the jail inmates, and that there was no difference at all between those who had SPD and had been arrested 1 time and those with SPD who had been arrested 11 times or more. There was no differences. There was some statistical difference between prisoners and SPD in number of arrests, where it increased as they'd been arrested more. So we see, for example, 12% of prisoners with SPD had only been arrested once, whereas those 11 times or more had been, about 18% of them had SPD. We also looked at total time in a correctional facility. So this is how much time in your life prior to the current facility have you spent incarcerated, and this also included juvenile justice facilities, juvenile facilities. Again, not a whole lot of statistical differences for SPD. We see that prisoners are pretty even down the rows. And same thing for jail inmates. There was not a lot of difference between the percentage who had SPD and reported no prior time, and those who reported 5 years or more, 1 to 5 months, 6 to 11 months. The only difference is 1 to 4 years, which, interestingly enough, is actually lower than some of the other measures as well. So we can't even say that there's a clear decrease or increase in that pattern. So this table looks at treatment, and we only looked at those who reported a mental health illness. So the people who basically got screened out as saying that they did not have one and did not meet a score of 7 or more, they were not asked this particular question. So only the ones that reported got included into this analysis. So this slide shows SPD, and the numbers circled in red, I just did that to highlight that those are kind of your totals. So we see that 74% of prisoners with SPD have ever received mental health treatment during their lifetime, and this compares to 73% of jail inmates, so very similar. Again, we don't know how long ago this occurred, where it occurred, why it occurred. We just know that it occurred. Then we've also asked about mental health treatment received since admission to the current facility. And we see that 54% of prisoners had said that yes, they have received treatment. And this was statistically higher than 35% of jail inmates with SPD who reported the same. Prisoners were more likely as well to receive each individual form of treatment. So prescription medicine was higher, 46% of prisoners versus 30% of jail inmates with SPD. And the same held true for counseling as well as prescription medicine and counseling. Likewise, the pattern for currently treated for a mental health problem, and that's current at the time of admission. I'm sorry, not current at the time of admission, current at the time of the interview, so the time that they did this NIS interview. And we see again, prisoners with SPD had a higher percentage of them reported they were currently receiving treatment, so 36% versus 30%. However, there was no statistical difference between prisoners and jail inmates with SPD who said they received prescription medicine. But prisoners were more likely, about twice as likely, actually, as jail inmates to say they've got counseling, 26% versus 13%, and to have received a combination of meds and counseling, 20% versus 9%. And this is the same table except with the other indicator of a history of a mental health problem. And we see that the treatment rates are actually a little bit higher. And that kind of makes sense because you would think that if you've been told, you were probably in the course of getting treatment as well. So here we see that 88% of prisoners who were ever told they had a mental health problem received mental health treatment at some point during their life. And this compared to 90% of jail inmates. We see that 63% of prisoners who were told they had a problem have received treatment since admission, and this was statistically higher than the 45% of jail inmates. However, when we looked at those who had been told they had a mental health problem and were currently receiving treatment, there was no statistical difference. So prisoners and jail inmates were as likely to say that they were currently being treated for a problem.
We're getting a few questions again.
Yep.
One's related to the definition of mental health treatment. Does that include treatment for substance use disorders?
No, and that's a good question. This was specific only to mental health problems. It did not include substance use. Yes.
So they can stay tuned for the next part of the presentation.
Exactly.
For more on that.
Yes, we actually separated mental health treatment from drug and alcohol treatment.
Okay, great. And then the other question that we're getting, which kind of builds on some questions previously, is are you able just to speak a little bit about the decision to use self-reported data versus the link to criminal justice data reports? I'm
not sure I understand that question.
Okay, so I think it's related to the K6 was a self-administered survey, and so in the question, I think they're saying, you know, that in their experience of working within a facility, that some of the people aren't great historians when it comes to their own past history of treatment or their records if they do have behavioral health issues. So they were just curious about, you know, the idea of the self-reported data versus having the ability to link it to their files within their criminal justice system.
We wish we could do that. We've actually, with one of our most recent surveys, they're exploring linking the survey data to administrative records, but that does not include health data or medical records. Some of that is because all the systems are different. Not everyone has electronic medical records. So we know self-report isn't always ideal, and we know that there's telescoping issues and, you know, recall issues and those biases that come into play. But it's basically our best avenue. If we were doing a smaller study and only looking at one facility, we probably could easily more compare the survey answers to official records. But in a survey of this size and magnitude, the cost and expense and burden that the survey does, it just would not be possible to do that.
And that's a great point, and something for people to think of who are calling in from a local jurisdiction, that they might have the ability to do some more sophisticated reporting based upon their increased interaction and their access to data at their, you know, at the county level or even at their state level agency.
Right, and I would encourage people who have an interest and the ability to do that to do that. It's just outside of our scope. I mean, that would just be millions and millions and millions of dollars to do. So unfortunately, we do just take everyone at basically at face value, and that's standard operating procedure for surveys. We just kind of have to take what people say when we're doing self-report data and acknowledge that there are possible biases in the reporting. Now that said, if an inmate who was sampled was very ill, you know, in the throes of psychosis, chances are they were not interviewed, either because the facility wouldn't let us do that or the inmate couldn't get through the survey. So that does happen, and so I will say kind of as a caveat that sometimes the sickest inmates might not have been captured in this survey. And again, that was often for security purposes and sometimes just the inmate's inability to participate. So this is the last one actually for the mental health report that I'm going to cover, and this looks at rule violations. So prisoners and jail inmates who were written up and charged with assault, and that includes a verbal assault and physical assault against correctional officers or staff. And then we also looked at assaults against other inmates. So the numbers highlighted in red, the middle column is your SPD, and then the one on the right is your history. Our comparison group was the inmates with no indicator of a mental health problem. And you can see pretty clearly that all of the percentages did test as significant. So prisoners and jail inmates with SPD were more likely to have said that they were written up or charged with a verbal assault, physical assault, or assault against other inmates. And this was also true of those with a history of a mental health problem, where they were more likely to have said they were written up or charged with assaults. Now again, because I have a feeling this question may come up, somebody who is being held in perhaps solitary confinement or, you know, restrictive housing related to rule violations might not have made it to the survey. The facilities had the right to decline inmate participation if they felt it would jeopardize risk and security. Okay. So a few report limitations. We have talked about some of these already. This is self-report data, and it's not verified. We take it at face value. We don't know the time period or setting in which an inmate was told they had a mental disorder. We don't know if they still have that mental disorder, if it's still, you know, a problem for them. The lifetime measure is conflated with access to health care, access to mental health care, and treatment-seeking behavior. And I'm assuming many on the phone are aware that there are differences. There are sex disparities and race and health disparities, economic disparities that influence who gets treatment and who doesn't, and who attempts to get treatment and who doesn't. We have limited information on the relationship between kind of the onset of the mental health problem as it relates to their current offense and incarceration. So we do caution people not to say, oh, you know, these people are definitely here because of the mental illness. We don't know that. And vice versa, it wouldn't be correct to say, oh, these 15% of people that have SPD, it's because they're in prison. We don't know that at all. This is national level data, but it is representative at the national level. And trends cannot be produced, as we talked about, and this is primarily because, and I mean trends with the 2006 report. And this was largely because the K6 scale was not included on those past surveys, so we had nothing to compare it to. It would have been apples to oranges instead of apples to apples. Okay. So summary of findings, these are our big takeaways. Prisoners were 3 times more likely to have SPD than the total adult general population. Jail inmates were 5 times more likely to have SPD than the adult general population. Female inmates were more likely than males to have an indicator of a mental health problem, both SPD and ever told. More white inmates had SPD than Black or Hispanic inmates. Prisoners incarcerated for a violent crime were as likely as those incarcerated for a property crime to have SPD or a history of a mental health problem. There was no difference among prisoners or jail inmates who had SPD by sentence length. And then prisoners and jail inmates with an indicator of a mental health problem were more likely to have a rule violation than inmates who did not report that they had one of these indicators. And that brings me to the end of the mental health report. Okay, so next I'm turning it over to our drug use report, and this was written by myself, Jessica Stroop of BJS, Stephanie Zimmer, and Marcus Brzozowski of RTI, my wonderful co-authors. And as I said, the reason that we're doing the 2007-09 data is because it was determined that the 11-12 NIS data was biased towards those who had not reported sexual victimization, did not report mental health. And we know that those often co-occur, so that one in particular may be important, and biased towards English speakers. So yes, we know this data is a little outdated, but it's still, believe it or not, the most reasonable data, the most recent usable data that we have, and it will continue to be the most recent usable data we have, I'd say, for about another 2 to 3 years, particularly for jail inmates. And I think someone else wanted to know if the mental health data was the most recent that we had, and it is. And likewise, it'll continue to be the most recent for a few more years. So our drug use report, one of the differences between this and the mental health is that we only looked at state prisoners. The reasoning for this is kind of long. If somebody's interested, I can answer that through email. But we did only look at state prisoners and sentenced jail inmates. And our reasoning for the sentence was that we thought that unsentenced jail inmates were probably less likely to be getting substance use treatment or participating in a program, so we made the determination to just focus on sentence. We look at 8 types of illicit drugs, and these are marijuana, hashish, cocaine, crack, heroin, opiates, depressants, stimulants, methamphetamine, which we pulled out as a separate category from stimulants, hallucinogens, and inhalants. And we look at drug use over different time periods, so lifetime drug use, regular drug use, at time of the offense, which is one of my favorites, month before the offense, and then also whether they committed the offense to get money for drugs or drugs. We compare inmates to the general population again. We look at demographic information. We do some limited trends with this data, and we also look at drug treatment while incarcerated. And I should say before I forget that our drug use survey data, it only looks at drug use prior to incarceration. We do not ask about drug use while incarcerated, and this is because we can't ask them to incriminate themselves. So all the drug use data refers to their use prior to their current incarceration. Again, this data comes from NIS, and this comes from the first 2 surveys, which we combined to get more data, 2007 to 09. Since I've already covered this, I don't want to beleaguer the point. And again, we use NISDA data collected by SAMHSA, and this is because they've got that great criminal justice indicator. They use the same variables we do for the most part. And so we were able to pull 2007, 8, and 9 surveys and then do the rolling averages. And again, all of this general population data has been standardized so that it looks like our prisoner and jail population. So our drug dependence, our drug use data is based on the DSM-4 because that's what was out at the time the survey was administered. So our questions, I didn't put them here word for word, but we use the same criteria that's in the DSM-4, and the questions are almost word for word. So if an inmate was considered to have met the criteria for drug dependence, if they had 3 or more of these symptoms in the year prior to the current incarceration. So again, there could be some, recall bias, but we've got to take this at face value. For drug abuse, it's the same thing. It's modeled after the DSM-4. If an inmate met 1 or more of these symptoms in the year prior to the current incarceration, and if they did not meet the criteria for dependence, they were considered to have a drug abuse problem. Now, one limitation of this data is that a diagnosis of drug dependence or drug abuse ideally should be drug specific, so cocaine dependence or heroin abuse, and not based on drug use as a whole. However, NIS data did not permit an analysis of dependence or abuse symptoms by individual drug type. Again, we're we're a criminal justice agency, and all this data that we got on correctional health was kind of gravy on top of the sexual victimization data, which is what this survey was designed to do. So we weren't able to get into all the details of each symptom for each kind of drug that they said they used. So the drug abuse and dependence data is drug use as a whole.
And does it count alcohol as a drug, or is it only, is it not included?
Good question. Alcohol was excluded, as was nicotine.
Okay, thank you.
Yes, so it's what we're calling illicit drugs only, although even that with marijuana is a little different now. So this is our figure 1. It's our big takeaway again, and it shows the percentage of prisoners, inmates, and total adult general population who met the criteria for drug dependence or abuse. For state prisoners, 58% met the criteria for either, or combined, I guess. 42% for dependence and 17% for drug abuse. For jail inmates, 63% met the criteria for either, 47% for dependence, and 16% for abuse. And now this compares to the total general population, where only 5% met the criteria, so 4% for dependence and 1% for abuse. And so we see that there is a statistical significant difference between our inmate populations and our adult general population, and it's a pretty sizable difference as well. When the general population was broken into the criminal justice involvement categories, similar to mental health, we saw that the arrestee population looked closer to the inmates. So for prisoners, or when the general population is compared to prisoners, 4% with no involvement had dependence or abuse, compared to 12% under supervision, and 19% who were arrested met the criteria for dependence or abuse. Now, I didn't include the table here, although I really should have, but we do have a table of the demographics of state prisoners and sentenced jail inmates who met the criteria for drug dependence or abuse, and this is table 2 in the report. I will highlight, though, that the findings were pretty similar to the mental health report. In particular, the findings between sex differences. Females were statistically more likely to have said they had a drug dependence or abuse problem compared to males. For prisoners, this was 69% of females compared to 57% of males. And for jail inmates, 72% of women, so almost 3/4 of female jail inmates met the criteria compared to 62% of males. We saw a similar pattern with race and ethnicity, where our white inmates were more likely to have met the criteria when compared to Black and Hispanic inmates. Regarding age, similar thing, where our oldest population, 55 or older, were the least likely to have met the criteria. So for example, about 26% of prisoners 55 or older met the criteria compared to 64% of those 18 to 24. And again, this is available in the full report online, and this is table 2 in the report. So this table looks at drug use, and this is the ever drug use. So ever in your life did you use this drug? And of course, inmates could have used more than one drug type. We were able to do some trends with this. The 2004 data comes from our survey of inmates in state correctional facilities, which has been renamed SPY, the Survey of Prison Inmates, and some of you all facilities may have recently participated in SPY. And then the 2002 data comes from our survey of inmates in local jails. And that SILJ survey is still our most recent standalone jail survey that looks at this type of information. For prisoners, there was a very slight, but statistically significant, decline in ever drug use from 2004 to 07-09. It went from 83% down to 82%, but there was no statistical difference observed between sentenced jail inmates. We saw no difference across time periods for both prisoners and jail inmates regarding the use of marijuana as well as cocaine crack. And for methamphetamines and prisoners, we also did not see an increase and the percentage who used this in 2004 compared to 07-09. Now, we did see increases for some other drug types, and some of the ones that I want to flag are heroin opiates. And this data is before the onset of the current opiate epidemic, but it provides kind of a nice baseline for what the story was prior to when that started to occur. So I think it's still usable. But we see that heroin opiate use did increase. So for prisoners, it went from 23% who said they'd ever used this up to 26%. And for jail inmates, it went from 21% in 02 to 28% in 07-09. Depressants also increased quite a bit. For prisoners, it went from 21% to 30%, and for sentenced jail inmates, it went from 22% to 34%. And the last one that we found, my co-authors and I found interesting, was the increase in hallucinogens, because that was something we weren't expecting. We actually expected there not to be a change, and we saw instead for prisoners, it went from 32% to 42%, and for jail inmates, 34% to 46%.
For the opioids and the depressants, some,
yes.
Those can also be prescription drugs. Was there a differentiation between the type of use, whether it was
yes.
prescribed by a doctor or not?
Yes, it was, and it was actually all the little footnotes you can kind of see are in these tables that explains what exactly fell into these categories. But yes, if it was a prescribed depressant, something like that, then that would not have been included or should not have been included by the inmate in this category.
Okay, so for heroin and opioids, so the prescription drugs wouldn't have been included, even so that actually could affect the rates as well, because we know that a big part of the opioid epidemic is the prescription drug use.
Right, right. And again, some of this is inmate perception as well, so we never quite know. This is the same table, except it looks at regular drug use, which was defined as using the drug for once a week, at least once a week for at least a month. I'm not going to stay on this slide too long because you can see that everything largely increased. The only thing that did not increase was the use of inhalants by sentenced jail inmates. It remained about 4% in both 02 and 07-09. But again, we can see that there was a slight increase in heroin opiates. For prisoners, this went from 13% to about 17%. And for jail inmates, the sentenced ones, this went from about 12% to 19%. And we also saw the same increases in depressants as well as hallucinogens. Those same patterns of increase were present as well. So we have seen that drug use, regular drug use, appears to have increased as a whole among prisoners and jail inmates over these time periods. Okay, so this one is our prisoners and jail inmates who use drugs at the time of the offense. So the most current serious offense for which they're now incarcerated, were you using drugs at the time? 42% of state prisoners said yes, and 37% of sentenced jail inmates said yes. For prisoners, marijuana was the one that they were most likely to have said that they were using. This was followed by cocaine crack, and then third was stimulants. For sentenced jail inmates, it was quite similar, with marijuana being the first most reported, followed again by cocaine crack. Heroin and opiates was 8%, which was the same as stimulants, also 8%.
So would those stimulants also include synthetic drugs that we're seeing more frequently now, such as spice or bath salts?
They could have, but I'm not sure how much of that was on the streets either at this time. I think it was just kind of starting around that time, but that's probably where they would have fallen, would have been in that. But I don't believe we specifically specified or called those out in the questions. Okay. So this is the table of prisoners and sentenced jail inmates who committed the offense to get money for drugs and by type of offense. Perhaps not surprisingly, we see that property offenses were the most commonly committed. 39% of state prisoners said that they committed their property offense to get money for drugs or for drugs, and 37% of sentenced jail inmates said the same. A drug offense was the second most mentioned by 30% of state prisoners and 29% of sentenced jail inmates. And for violent offenders, about 15% of state prisoners said that they committed that offense to get money for drugs or for drugs, and 14% of sentenced jail inmates also said the same. And just ignore that little asterisk down there by the other public order. That's a typo. That shouldn't be there. This slide has some demographic information. We looked at drug use in the month before offense. We found that much like our drug use disorder data and our mental health data, females were more likely than males to report drug use in the month before. This held true for state prisoners as well as sentenced jail inmates. We see again that whites were more likely than blacks or Hispanics to report drug use in the month before. So for prisoners, this was about 42% of whites compared to 36% of blacks and 37% of Hispanics. We see that drug use significantly decreased by age for both prisoners and sentenced jail inmates. For state prisoners, violent offenders were less likely to have used drugs in the month before the offense than those incarcerated for a property crime, 47%, a drug offense, 47%, or a public order offense, 44%. For sentenced jail inmates, it was quite similar, where violent offenders, 54%, were less likely to have used drugs in the month before compared to property offenders, 63%, or drug offenders, 67%. And these full tables of this demographics, again, is available in the drug use report.
Jennifer, we're getting a question just definitionally. You went through a lot of different crime categories, and there was a couple of questions on where would prostitution or potential prostitution to acquire drugs fit in within the table?
That is a really
Or is it just not? I mean, it looks like it's not a separate category.
Yeah, it wasn't. It's not called out, and that's not one that we typically separate out when we present our data. We tend to use kind of these larger offense categories. My guess is that it would be either in the other public order or it actually was excluded. But that is a good question and a good point. Okay, so this looks at race and Hispanic differences in regular drug use among state prisoners. Our white inmates or white prisoners are in the green bar, black is in the gray, and then Hispanic is the light green. White was our comparison group, and the differences between white and black and Hispanic inmates was statistically significant for both any drug use as well as cocaine, methamphetamines, and heroin. Let's see. So black prisoners were less likely to have regularly used cocaine, crack, about 28%, and this compared to whites, about 42%, and Hispanics were 31% for that particular category. You can see visually that blacks were definitely the least likely to have used methamphetamine compared to whites, and looking at Hispanics as well. And this is the same chart except for our jail inmates, and it shows a very similar pattern where white inmates for both any regular drug use of any drug, in addition to kind of our three comparison groups, cocaine, meth, and heroin, whites were more likely to have used those drugs when compared to black and Hispanic inmates. So this gives you a little bit idea of perhaps who's using the drugs. This is the table for state prisoners, and it compares our prisoners to adults in the general population. Now, we couldn't ask adults about the month prior to the admission to the current facility, so their month before measure is based on the month before they completed the NSDA interview, whereas state prisoners, it continues to be the month before offense. So 39% of state prisoners in the month before said they used any drugs. This compares to 12% of the total GP, about 11% of the non-criminally involved in the last 12 months, compares to 24% of those on probation or parole, and 32% of those arrested in the last 12 months. Almost all the differences are significant between the prisoners and adults in the general population. The notable exceptions were marijuana, where 28% of state prisoners said they used this compared to 26% of those who were arrested. And the other difference is heroin, where about 7% of state prisoners said they used this, and this was statistically not different from the 7% of arrestees who also reported the same. There is a similar table for jail inmates, kind of for space and time purposes. I'm not showing that table. It's table 13 in the actual report, and it shows the exact same pattern where you see increases where the jail inmates are more likely than your general population groups to have reported regular use. Okay. This is our treatment, and this is specific to drug treatment. This excludes mental health treatment. It also excludes alcohol. That was also its own separate category. So, and this also for the prisoners and sentenced jail inmates, the people in this bucket are those who met the drug dependence or abuse criteria. So we didn't ask everybody if they've received treatment. So of the state prisoners who met the criteria for drug abuse or dependence, 29% said they had participated in any drug treatment program since admission to the current facility, and this compares to 22% of sentenced jail inmates. 19% of our prisoners said they participated in a self-help group, and this is down towards the bottom, and that was the one that they were most likely to have said they participated in. And this was followed by some kind of drug awareness program, drug education program, which was reported by about 15% of state prisoners. For jail inmates, self-help groups, this is kind of your NA type model, your Narcotics Anonymous. 12% of sentenced jail inmates said that yes, they had participated in this since admission to the current facility. Now, we don't know if they're still participating in it or why they were participating in it or their motivation for it. We simply just know that they have said that, yes, I have participated in some type of treatment program since admission. So one of the things that we wanted to look at, because we were aware that in some facilities there's guidelines as to who can receive treatment and when. And sometimes this depends on somebody's release date. Sometimes it depends on someone's arrival date. So we were curious to see how those factors impacted treatment. And really, we did not see that much of a pattern. 60% of state prisoners who had been in the current facility 6 months or less said that they had received, participated in treatment, and this compared to 57% who had been there longer than 6 months. Now, this did test as significant, but you can see that the magnitude of the differences is relatively small. When we look at state prisoners in time until release, about 64% who had 12 months or less said, yes, I participated, versus 58% who said, oh, I have more than 12 months until release. And this is their expected release date. For sentenced jail inmates, we're also looking at about 2/3 of the population, 2/3 of those with the drug dependence or abuse criteria. 63% have participated since 6 months or less, and 66% more than 6 months. And we expected this, we weren't surprised that this tested, but we expected it to be a little different and to see, particularly for jail inmates, we thought this would be a starker difference. And there was no statistical difference at all between the percentage of sentenced jail inmates who received program or treatment at 12 months or less until release compared to those with more than 12 months. So that was about 63% of both groups. So in relation to treatment, of course we can't ask the general population if they've received treatment since admission, but the NISA did ask them if they participated in the last year. And this was again for those who met the drug dependence or abuse criteria. So comparatively, you can kind of see that our inmates are receiving some treatment. About 28% of prison inmates, just as a reminder, said, yes, I've received some treatment since admission. And so this would essentially compare to the 13.7% of the general population. Likewise, our jail inmates who reported treatment since admission, that was 22%, which is also higher than your 14% in the general population who said, yeah, I've received some drug treatment in the last year. So this data can kind of speak to the treatment gap. Here we often hear a fair amount about the treatment gap in prisons or jails, but there's a treatment gap on the outside as well, and this data is a reflection of that. Likewise, we see that self-help groups was the most commonly frequented mode of treatment, if you will, for the general population. And you also see that this increases with their kind of criminal justice involvement. Now, what's sort of interesting and something that we don't know for sure, we see, for example, that 30% of those on probation or parole have participated in a self-help group. This could have been part of their court order. It could have been part of their sentence or terms of their probation or parole. So we don't know some of that information and the motivation. Likewise, that person could have just gotten out of jail and the treatment they received was actually in the facility and not in the community. And that same caveat goes for those who were arrested as well. Incidentally, NISA did ask if they received treatment in prison or jail, and we see that 2% of the total general population said that yes, they did. About 5% of those on probation or parole, and about 4% of those arrested said that that was the location they received that treatment. Summary of findings, these are our big takeaways. 58% of state prisoners and 63% of sentenced jail inmates met the DSM-IV criteria for dependence or abuse, and this was much higher than the 5% of the total general population who reported the same. The percentage of inmates who met the DSM-IV criteria was higher for property offenders compared to violent offenders. A larger percentage of females than males used drugs in the month before the offense. And a larger percentage of females than males also met the criteria for substance use or dependence as well. A larger percentage of whites compared to blacks and Hispanics regularly used cocaine, crack, heroin, opiates, and methamphetamines. And among those inmates who met the DSM-IV criteria for dependence or abuse, 28% of prisoners and 22% of jail inmates participated in a drug treatment program since admission. So thank you all very much. I appreciate your attention and interest in our work. My email address is here on the slide. I'm happy to answer questions and comments if you want to shoot me an email and discuss any more of this data in more depth. Thank you all very much.
Thanks so much, Jennifer, for those two great presentations. I'm just going to briefly talk about some of what we can think about of how to translate to this information a little bit locally, and then Bonnie's going to talk about some brief research and evaluation considerations and building that strong partnership. And then we may have time for 1 or 2 questions at the end, so if there are any burning desire questions, please let us know or feel free to reach out afterwards, and we're happy to answer your questions as Jennifer indicated. So one of the things that Jennifer mentioned is that they really compared the data in the drug use piece to the National Survey of Drug Use and Health, and the Substance Abuse and Mental Health Services Administration provides a behavioral health barometer with state-level data. They're on volume 4 of this, which they have a 2016 version. So this is a good option if you're not really sure what the rates are within your state of people who have substance use disorders and mental illness. Those questions are on the survey, so it can give you a comparison point, which not all criminal justice professionals might be familiar with. And Jennifer did talk a little bit about being able to use some of this data for comparison. She did indicate they used the K6, so if your jurisdiction also had K6 data, then you could do a direct comparison. But it's still important to just have this information as a point of reference. The other consideration that I think this brings up in looking through all the data they've collected within this is what information are you collecting at a local level? And then is there a standard procedure for getting some of this information, such as screening in the jail or prison facility or within their booking process? And really, does the jurisdiction know how many people within their facility has mental illness, has substance use disorder, and do you have the demographic and gender breakdowns for that within your facility? From working with jurisdictions around the country, we know it's really a struggle to get standardized data on everyone who's coming through your jail or prison. So this was part of the reason that we partnered with the American Psychiatric Association Foundation and the National Association of Counties on the Stepping Up initiative, which is a national initiative to reduce the prevalence of people with mental illnesses and co-occurring substance use disorders in jails. And through this, there's 383 counties who have passed resolutions under the Stepping Up initiative. In the Stepping Up initiative, there's 6 key questions, and there's a document available on the Stepping Up website, which is stepuptogether.org, that goes through these and thinks through considerations to reduce the number of people with mental illnesses and co-occurring disorders in jails. And a piece that I think really relates well to this specific issue would be the timely screening and assessment process. So do you actually know who's in your facility? And one way we talk about this is to think through how to reduce the number of people with mental illnesses and substance use disorders within your facility, how to shorten the average length of time, increase the percentage of people who are connected to the right services and supports, and then that will in turn lower the recidivism rates. When you're thinking about the screening and assessment process specifically to get that baseline data, one thing that we found in working with jurisdictions across the country is that really looking at a system-wide definition for mental illness and substance use disorders becomes really important. So really thinking through, okay, is this the same at your jail facility as it is utilized in community corrections, as is utilized in your local community mental health centers or your local addiction treatment facilities, to make sure that all of the definitions are similar across like agencies and that you're able to track referrals from facilities back into the community. So I'm going to now pass it over to Bonnie to talk a little bit more about further considerations you could have for research and evaluation.
Great, thanks, Sarah. So, you know, now that everyone has had some opportunity to take a look at this information and digest it, you know, there's some thoughts that we have for, you know, our action research partners out there to think about. So now what happens if we want to do something like this in our jurisdiction? How can we learn more about what happens in our county, in our state, or just in our local facility? And so some things to really think about when you're meeting with evaluators, or if you are the evaluator who's listening to this, is firstly, how will the data be collected? So if you're doing a survey, just as the folks over at Bureau of Justice Statistics had done, are people going to be surveyed, and how will they be surveyed? Or will you be having data access from case files or an MIS system? And of course, what information sharing agreements are going to be needed in order for you to begin this work? Another question you're going to want to be thinking about with your evaluation partner, or if you're going to be engaging an evaluation partner, is who's collecting the data. So who is actually tasked in doing this work? And if it's going to be people who are local in your facility, perhaps people in your probation office, court, how are you training these individuals in order to obtain this information? Do evaluators have needed access to the population and records? You know, do you actually have a way to go into the facility to do these surveys, such as Jennifer and her colleagues did? What kind of training is needed for staff to do this work? Do you need to do interview training? Do your staff have information and abilities to do the data entry that's needed? Perhaps you have some folks on staff that do analysis. Do they have the opportunity to learn more about data analysis in order for them to participate in this work? And of course, what's super important when you're looking at implementing any type of evaluation method is how are staff getting feedback and coaching about this work, so that you don't just get your information at the end and realize we could have had more help for interview training. How can we really have a feedback loop for supervisors to make sure that the data is being collected in the best way possible? So then, you know, we want to think about what happens after your evaluation. Do your evaluations share this information with institutional staff? Are you sharing this information with your program staff so they can learn more about who's living in the buildings? How can this help you to learn more about your population? We had a really great question come in from one of our listeners about how does this information impact security levels and housing restrictions. This is exactly how we can start to learn more about that. Do we have people with more substance abuse disorders or mental health illnesses living in certain mental observation units and general population? You also want to figure out how can evaluations such as this really identify your service gaps. So now that you know who this population is, do you have the programs available to be responsive to this population? What education or training is useful for staff? So are staff trained on this? Does your staff know what mental illness looks like in jails and prisons? Do they understand what substance abuse disorders looks like within your facilities? What kind of coaching and education can we help provide your staff to do their job in a better way? And then, of course, how can your evaluation partners help you participate in planning new work? So now that you know what the gaps are, how can they help you figure out how to roll out new programs with implementation science really at the heart of all this work?
Thanks so much, Bonnie. And Jennifer, while we're on this topic for evaluators or researchers, do you have any thoughts on how the data that you presented can help or be utilized by evaluators out there looking to work with this population?
I think our data is good. It's kind of a national benchmark to kind of get the big overview, and then from there people can kind of drill down and see what the states look like and the communities and kind of compare that back to us. But again, you know, the comparisons are difficult if you're looking at apples to oranges. I have become a fan of the K6, admittedly. I was skeptical about it at first, but understanding more about our particular needs to measure this population and to get this information in a very quick, you know, kind of easy manner, basically meaning can we collect this information in 45 seconds. The K6 has become a good tool for that. So if people can, you know, adopt that measure or incorporate it or use it, then that would be good. They could then evaluate, well, hey, in my community it looks like this, in my facility it looks like this, in the national picture it looks like this. So I think that's one thing I could encourage people to do.
Great, thank you. And just we have a couple of questions just before we wrap up. One question was around the participant on the webinar noticed that you talked about male and females. Do you know if transgendered population a category on your on the survey that was administered?
I do not think it was on the NIS. I need to confirm that because I know we asked about sexual orientation on the NIS-3, but I cannot remember if we included a question on transgender identity. So if that person wants to email me, I can confirm that for them. And actually the survey itself is available on our website too. But I know moving forward, transgendered is something that we have included and plan on including in our inmate surveys.
Great, thanks so much, Jennifer. Now I see we are at that 3:30 mark, so I really want to thank you for sharing the data and your several years of work on this with all of us. And thanks to Bonnie for bringing her perspective and helping ask questions. And thank you to everyone in the field who is able to join the webinar. If you have any questions or follow-up, feel free to email any of us and we'll make sure it gets routed to the correct person. So we appreciate your participation, and thanks again to Jennifer.
Thanks, Jennifer.
Thank you all so much.
Thanks, everyone. Have a great day.